Probably the most important feature of Nmosd in Asia is the prevalence is higher in Asian populations than in Western populations. For example, in European countries, ratio of MS to NMO is like 200 to 1. In Japan, 3 to 1. Nmosd is usually one of the top 5 misdiagnosis of MS. They may be referred to us with the diagnosis of MS, but actually they may turn out to be something else, including Nmosd. The most important thing in terms of the treatment differences between the two disorders is that disease-modifying therapies for MS can exacerbate Nmosd. So the correct diagnosis is critically important. So for aquaporin 4 IgG positive Nmosd, of course, we have to prove that the patient is positive for aquaporin 4 antibody. In that new diagnostic criteria, we will clearly mention live cell-based assay, the number one recommended test. We recently published that the efficacy of biological agents, including satralizumab, is much better than corticosteroid alone or conventional immunosuppressive agents. They are essentially more efficacious, and the safety profiles are relatively good. Although we have to closely monitor adverse events, in particular the infections. Since all these drugs suppress the immune system, we have to pay attention to infectious diseases all the time. As for the genetic aspect of the therapeutic efficacy of biological agents in Japanese population, previously it was reported that 3.5% of Japanese people harbor complement C5 polymorphism. If your patient harbors this genetic polymorphism, since the complement inhibitor cannot bind to complement C5 properly, so you cannot expect the therapeutic efficacy. So this genetic test should be done prior to the first dosing of complement inhibitors. Some patients may hate injections very much, so they prefer long dosing intervals like the one with once every 6 months. We cannot neglect the patient preferences. For policymakers, I think firstly the aquaporin 4 antibody, in particular the highly sensitive antibody test, should be available anywhere. But highly sensitive AQP4 antibody tests like a live cell-based assay may not be available everywhere. Some investigators are trying to develop immunoblot assay, which is time-saving, cost-saving, but they can get the results very quickly, and they do not have to maintain the cell cultures throughout the year. The network of neurologists may also be quite important, because not everybody is an expert on Nmosd, but if he or she suspect that this patient may have Nmosd, then if there's a network to refer the patient to an expert, like big hospitals in Taipei, then the expert can make a diagnosis. Another message to policymakers may be that unfortunately these highly effective biologics are not cheap. Their drug prices are relatively high, and in many countries, because of the high prices, availability may be quite limited. So that's what I want policymakers to deal with. One relapse of Nmosd may be a big change in their life. They may become blind, they may become wheelchair bound. Then the government may have to pay more money. So preventing the relapse is quite maybe money-saving, life-saving. And as for the breakthrough in the next 5-10 years. If we can find biomarkers to predict relapse, this patient may experience a relapse next month. That's fantastic.